U mag gaan zitten. Please be seated. Esteemed PhD candidate, the doctorate board of this university, represented by us, has read your PhD thesis and the propositions that go with it, and we are ready to hear you defend it. Please take your seat. I now call upon Dr. Veerman to start our position.
First of all, let me start by congratulating you on the completion of your PhD thesis and on reaching this important milestone in your academic career. I know preparing a dissertation is a demanding and often challenging journey, and you have clearly invested great effort and dedication, and probably also intellectual curiosity in your work. Of course, I would also like to extend my congratulations to your supervisors. It's not only the chapters in your thesis, but also the impressive list of publications printed at the end of the thesis. So it's a pleasure for me to be here and discussing your work. Before we start discussing the thesis itself, I would like you to help me to explain what is it I see on the cover of your thesis. Because I see a fisherman in a boat going through some of tunnel or...
Very learned opponent, thank you very much for your kind words. And I'm very happy that you had the time to look into the cover a little bit more than maybe some other readers. I think this is a very nice representation of the cardiometabolic continuum. You can see the heart, which is a cave, and you know the heart is one of the most well-studied organs in the body. And this is a cave, and there is light at the end of the tunnel. But before we get into the tunnel, we have the streams of data that represents the data-wise approach we have undertaken in this thesis. And in the walls of the cave, you have lipid droplets as well as a fatty liver and a pancreas. And there are two people exploring because not one can do it alone.
Oh, okay. Thank you for this clear explanation. I would like to start discussing with you chapter 2, in which you are looking for an easy model based on questionnaire to predict the prevalence and incidence of type 2 diabetes. And in this case, the incidence is a definition of developing type 2 within 8 years. Maybe start off with a simple question. What do you think is more important? Should we implement something so that we catch everybody, or should we reduce cost of screening as much as possible?
Thank you very much for the question. I think the best thing we can do is to include people with high risk into tools. And this is also what we try to do in this chapter. If you go to page 45, figure 3, you can see that we don't want to screen everybody. We have made a 3-group stratification. And we tried with this analysis to reduce the number of individuals that need to be screened so that we capture at least 1/3 of the cases. So this approach exemplifies that we should not be including everybody, but we should be focusing on the people with high risk.
Yes, so in your discussion, you indeed mentioned that to capture 1/3 or even 2/3, you need to screen anywhere between 10% of 23%, and even if you want 100%, of course, you have to screen everybody. With respect to this, is it now more important to have a high negative predictive value or a high predictive value, positive predictive value?
We prioritize negative predictive value to have a high accuracy of negative findings and to not claim false reassurance to the people, because if we were to implement it at scale, we would need many people to take the test.
Yeah, but on the other hand, the positive predictive value, which did not make it to the manuscript, but only in the supplement, probably because also the positive predictive value is not that high.
Oh.
That would mean that if you screen somebody as a high-risk individual, yeah, how would it work? Because the incidence is somewhere in 8 years, so probably you need follow-up visits and you need additional tests. So I wonder with these numbers, what the practical and economic implications of these results are.
I understand your question. So if we were to deploy it to the whole population, then we would be focusing on negative predictive value. If we were to screen this small strata only, then we should prioritize positive predictive value. So if we were to retest individuals or do follow-up testing, then we should recalibrate the models and have a higher, or at least aim for a higher positive predictive value.
So, but I can also imagine that maybe you want to be as efficient as possible in your screening, but on the other hand, capture as much people that will develop. So it's a sort of a trade-off.
Exactly.
Is then AUC between sensitivity, specificity then the best metric to do that? Or could you envision some other criteria to determine what is now the best cutoff for identifying high risk or low risk or intermediate risk patients?
I think the AUC is a good metric. There are definitely other metrics, but it's an easy metric also for clinicians to understand. So we're not targeting a niche of deep learning specialists or people that are very well versed in digital technologies. But I think AUC has, of course, limitations, but it is something that you can explain to a clinician and they will be able to understand.
But can you maybe also envision that something like a decision curve analysis would be very interesting to do? Because yeah, setting thresholds has the implication, of course, on sensitivity and specificity, but also on what will happen if you have a false positive in follow-up screening that costs money. So you take into account and the resources that are necessary to do certain screening with a certain threshold. Would that not be more practical?
I think this is definitely something that we would consider in follow-up papers, decision analysis. But for now, it was easier to implement an AUC metric to have a very clear comparison also with other models that are currently deployed in clinic, which have also been reported based on AUC findings. So then this would make an easier and more fair comparison, as you can see on page 43, figure 2.
Maybe I still have a room for a little question. So you have the AUC. But of course, you also have with logistic regression, you get a probability, and the higher the probability, the more at risk a patient is. And AUC just gives you a classification, is it correct, yes or no, and what is then the sensitivity and specificity? Did you perform any calibration analysis? Because I can imagine that the probability of developing type 2 diabetes is different, for example, in the UK Biobank versus the lifelines or for other ethnicity cohorts?
No, we did not do a calibration for this paper.
But do you expect the same probability of developing type 2?
No, the probability is different. But by deploying the same model into a new, completely new biobank and still attaining very high and even higher than the test set AUC, this shows that the model is already well calibrated, most probably.
I see that our time is up. So ik geef het woord terug aan de heer director.
Thank you very much. Then now I call upon Professor Peil from the Leiden University Medical Center to continue the discussion.
Thank you, Mr. Rector. Esteemed candidate, Let me begin by congratulating you with your thesis. I was very impressed by the amount of work, the complexity of the analyses that you did, and the potential clinical applicability. It's very, very well done, I must say. And I also, by the way, appreciated your attention for ancient Greek wisdom. I found that very, very special. So congratulations, and also I would like to congratulate your supervisory team. I would like to discuss with you several aspects of chapter 6, and let's go to page 168, where I see figure 1. And you, in this chapter, you analyze the impact of GLP-1 receptor antagonists and SGLT2 inhibitors on the incidence of and prevalence of dementia in type 2 diabetic patients. And you use the TriNet-X platform as a source of patients. And this TriNet-X platform you described as a platform that includes almost 300 million participants, and then and it's divided, and they're from various parts of the world. And then in figure 1, you tell me that only 3.5 million of these 300 million have type 2 diabetes. Is that not a very, very low number, given the fact that in most populations, the diabetes prevalence is approximately 4 or 5%?
Highly learned opponent. Thank you very much for your good words for my work. Your observation is indeed very sharp. We see a massive decrease in the number of individuals. There is a problem with the TriNet-X platform that is well known, and this is that the data are continuously gathered by the EHR records of the different hospitals. And sometimes, while they load the data, some healthcare centers do not participate at a certain moment in the cohort. That's why we see this large drop in participants. So this is a known limitation of the platform.
Okay, thank you. And do you think that this limitation affects your analysis?
This definitely affects the analysis in a way that we have less people with type 2 diabetes than they might actually be in the study. However, I would say that this gets the data back to the null. So I think this is something that our analysis is good at, in the sense that if there were more participants, then we would have even narrower confidence intervals. As you can see in the Kaplan-Meier, for example, CARES figure 2, page 176, you see that especially at the 10-year follow-up, the confidence intervals are starting to become wider. But at the beginning, they're quite narrow, so I think even with including more individuals, then we would still have reliable results.
All right, thank you. And then in the same figure 1, on page 168, you mentioned that just 309,000 of those 3.6 million people use GLP-1 receptor agonists or SGLT2 inhibitors. I found that a very low number as well, given the fact that it's included in many guidelines now, the treatment with these drugs. So why, do you think there's an explanation for that? Or do you agree with me first?
I agree with you. However, we have applied very, very strict inclusion criteria, as you can see the exclusion table. So we have tried to make an active drug comparator study, which includes patients that are active on metformin, so in the past 6 months, and you can see there the massive drop of individuals. So individuals that have a prescription of or use of metformin more than 6 months ago, maybe are not taking metformin, or maybe have not returned to their healthcare practitioner for a prescription. So that's why there is this big drop in numbers as well, but we have tried to apply as strict inclusion criteria as possible to have individuals that are well treated and under monitoring by a physician.
Thank you. And I didn't understand the reason why you excluded patients who did not use metformin. What was the reason for that?
So the reason for that is that we have tried to make a fair comparison across secondary anti-hyperglycemic drugs. GLP-1 receptor agonists and SGLT2 inhibitors are secondary anti-hyperglycemic drugs. So people that might be taking, for example, a GLP-1 without metformin, then this might be due to obesity. Or a person taking SGLT2 inhibitors without metformin, this might be due to chronic kidney disease or heart failure, for example.
Okay.
So we try to only include patients already treated with the primary drug indicated metformin and having an add-on therapy.
All right, that sounds reasonable. And then perhaps a final question about this cohort. I see that you excluded 763 people with dementia or history of dementia. And I found that, again, a very, very low number given the fact that you included the 309,000 people. Is that a reasonable number of people with dementia in such a large cohort?
Indeed, dementia is underreported and underdiagnosed in general, so there are a lot of cases missed under the radar, and this also reflects to the low incidence rates based on what is predicted to, what the amount of individuals is predicted to have dementia. So this is indeed a low observation for the people we excluded, and we also had in this paper a low frequency of dementia reflected by incidence rates.
Okay.
But
then
this
finally,
is based... Sorry, if I may add something to that.
Does that impact your analysis?
I think, again, it would impact the analysis by regressing the results towards the null. But on the other hand, we still have a considerable amount of individuals developing dementia throughout the study. So we still have good results.
Thank you very much for your answers. I'm completely satisfied, and I'll give back the word to the rector.
Thank you very much. I now call upon Professor Atsma, also from the Leiden University Medical Center, to continue the discussion.
Dank u wel, meneer de rector. Esteemed PhD candidate, first of all, congratulations. Professor Pell, can you mute your microphone, please?
Echo from Leiden.
Yeah, typical, but... So congratulations on completion of your nice book, and also congratulations to the promotion team. I think you have worked on a really important and relevant subject, and as a clinical cardiologist, your research piqued my interest on identifying those people at risk. And my question is, to start off with, is you have in chapters 2 and 3, you have studied a questionnaire, and which is a very easy way, in a way, to come up with the assessment of risk. And in your introduction, you mentioned, let's zoom out a little bit and talk about metabolic syndrome and see how that affects multiple organ systems, on the one hand. But on the other hand, traditional cardiology or traditional medicine at the moment is subdivided in these subcultures of cardiology, internal medicine, and what have you not. How do you foresee that we should implement and scale up such questionnaires in the future? Who should do it? Who should be responsible?
Highly learned opponent. I think this is a very good question and very timely as well. We see that this questionnaire, for example, could be implemented into large language models, which has already been done, partly by other groups. However, indeed, the responsibility and the target group are the main limitations here. So I think we should begin by lancing this to underrepresented and underserved communities. So for this chapter specifically, we have received a request from the United States. There has been a Martin Luther King Community Hospital in South LA, and they have reached out to us to see how they can implement this tool. which I think is a very nice way to have it as a pilot study. And this population doesn't get any risk assessment, any treatment, because the risk assessment tools currently implemented are very costly, as you know. So they wanted to launch it as follows. They wanted to launch the questionnaire at baseline, then have a lifestyle intervention, and then have a reassessment at 6 to 12 months to see if the AI predicted risk changes over time. And their focus was, this inspired me the most, because they wanted to foster both prevention and sense of community. So I think this is a perfect way to do it. Responsibility for these tests might be hard to attain, as with any other AI implementation currently, but I think this is a very nice initiative to begin with.
Yeah, so you were fortunate that they reached out to you, so there the initiative came from them. But suppose there's no initiatives. How can we implement such? Where do we start?
I think we should start by academic hospitals. Like in Leiden, I have seen how you work with a box. So people get devices at home, and then it would be very easy to start with adding some questions to be also informed about the risk, because we're collecting data, but we're not doing much with the data longitudinally other than when a bell rings. So
no, that's all true, but suppose we want to identify people who are not known in the hospital yet, so we want to pick them out of communities that are, as you say, underserved. Is there a role for GPs, for instance, or is it more of a community type of thing that you just mentioned? What's your feeling about that?
I think in the primary care it could be very well implemented. I mean, these are easy data to collect, and most of the questions we address are already asked and collected by GPs. So I think this is a very fair point to start in the primary line.
Okay. Yeah. Then in chapter 4 you add what they call a wet biomarker, GDF15, added to the questions. And as you know, there are many people, many groups reporting all sorts of biomarkers, all sorts of panels, and it's endless, as it seems. I understand that. But such a strategy, while could be effective by increasing accuracy, for instance, also comes at a cost, of course. I mean, the problems in healthcare are clear. Do you have an idea of how much it should cost to make it still worthwhile to have this approach of screening underprivileged societies, for instance, with a questionnaire and maybe some wet biomarkers? Do you have any idea of what would be still the optimum for it to have the increased accuracy on the one side, but not getting it overly expensive on the other side? What is your idea about that?
I think Dr. Hanpaio as Michail.
I'm sorry.
I think the question reflects to what cost should be for GDF15, for example. Currently, a company that is also doing the proteomics for UK Biobank, Olink, has a personal proteome analysis with around 100 euros. I think this is way too costly.
Which one is that, I might ask?
Sorry?
Who are they?
Olink. The company. Yeah, it's the company that does the proteomic analysis for the UK Biobank, and they also have commercial proteomic kits. I think I'm not an economist, but the perfect price would be somewhere around that of CRP. And I choose CRP specifically because CRP is kind of a parallel to GDF15, but then for the acute setting. So I think GDF15 might be like more of a chronic CRP. To reflect chronicity. So if it would cost around the same as the biomarker CRP, then this would be, I think, a reasonable cost to have in a test.
Okay, so they have a target now. Okay, is there time for one more? Small one? On those biomarkers, as I mentioned, everyone has its favorite biomarker du jour. What should be the strategy to come up with the ultimate set of biomarkers that are actually effective and still cost effective as well? How do we do that? Do we do the UK Biobank type of way? Do we put all the RCTs together? What is it? Or should we do something completely different?
If I may, I would like to ask my partner to read the number 4 of the propositions.
Omics inclusion in predictive models should be justified by incremental utility, not data availability.
Agree.
So that's what we tried to do also in this chapter. We did it in a data-informed way. We didn't pick our favorite one or the one that is more explained by biology, but we tried to see which one is the mostly correlated with our outcomes.
Okay, I thank you very much for these questions. I'm very satisfied. I hand the word back to you, Mr. D.
Okay, thank you very much. Then now I call upon Dr. Dilman to continue the discussion.
Thank you, Mr. Chairman. Esteemed PhD candidate, congratulations on a very impressive thesis, and not just only because you were able to get more than 42 panels into one figure, quite impressive and still very readable. I would like to take you to chapter number 4, where you show that GDF15 predicts or improves prediction for hepatic disease on top of a panel of non-invasive tests based on steatosis and fibrosis. This is done in a UK cohort representing the general population, an MASLD population, and a type 2 diabetic population. And in this paper you show not just that you improve the prediction for hepatic disease, but also probably for virtually all outcomes that you studied. So I think GDF15 is rising as a kind of Greek mythological predictor, even surpassing the Oracle of Delphi, I think, right? I was just wondering, how does this work mechanistically, right? So that so many different outcomes, and GDF15 seems to improve the prediction for all of them. How do you think that this works mechanistically?
Very learned opponent, thank you very much for your interesting question. I have done some studying at home, and I read that 13 years ago, one of your students, Dr. Mazagova, had defended her thesis in this aula on GDF15 in diabetic kidney disease. And back then, your group's work showed that GDF15 may be impaired in endothelial function when chronically elevated. So this aligns with our findings that it might be in multiple cardiometabolic conditions. And we confirmed this in a population level for the UK Biobank. By no means in this thesis do we support that GDF15 is causally increased for these cardiometabolic conditions, but we serve this as a proxy for predicting risk.
Yeah. I think we also showed that GDF15 actually might be mechanistically active, because we showed also that GDF15 showed impairment of endothelial function. So could you envision that GDF15 is working like a biomarker like albuminuria, where it is reflecting a kind of endothelial dysfunction throughout the whole body?
I think so, and this is very, very interesting to see that what we did in the modeling was not that we showed GDF15 or we didn't pick the biomarkers based on one disease and then the other disease and then the other disease, but we clustered the diseases all together, and still GDF15 had a very high correlation coefficient. So I very much would like to agree with what you say, that this reflects a body response and not a single organ response, most probably.
Mm-hmm. Okay. So I'd like to take you then to your statement that, okay, with adding GDF15 to the equation, you can better predict outcome for these patients, right? And GDF15 seems to be a very important part of that equation. But are we really able to target that part specifically using drugs that somehow are able to modify the GDF15 responses? And if these tools would exist, would you block GDF15 or would you stimulate GDF15?
Based on the literature, there is no clear evidence of a benefit of either introducing GDF15 or having it in knockout mice for chronic diseases. GDF15 has a dual role. At the beginning, the early compensatory increase is protective based on some research. So I don't think that it's such an easy answer to give if we should block it or not. My answer would say for the short term, this might not be a good strategy. But for the long term, we see that this is chronically increased. So I think that we should do more mechanistic studies to find out what is actually happening, and then with one of your studies with knockout mice, study what happens if we have a lack of GDF15.
Okay. You measure GDF15 at baseline, and then we have a kind of very long follow-up, perhaps even extending into decades, right? And you show that GDF15 at this very early time point predicts outcome. Do you have any idea what happens in between, right? Because it's such a long time.
This question is very good, and we have tried to do that. So if you go to chapter 5, page 144, figure 4, this is an analysis of trying to compute brain aging and quantify the effect of obesity or overweight on brain aging. And we have made a proteomic analysis. And the MRI data were only based on the imaging visit of the UK Biobank in 2014. But in the UK Biobank, we have also a small set of participants that have another remeasurement of their proteome, not only at baseline, but also in the imaging visit. These are around 10 times less, or 5 to 10 times less than the baseline visit. But we try to see if GD15 is implicated in brain atrophy, as shown in panel C of this figure 4. That is the only molecule that survives FDR correction for brain atrophy. And we don't see that anymore in the imaging visit. I personally think that this is because of a lack of big sample size. But there might be mechanistic evidence there as well, that maybe the effect on the brain does not survive after all this time passed, so which is like around 7 years based on the between the baseline visit and the imaging visit.
Is there time for your questions, though? Okay. Did you try to look at whether GDF15 actually correlated with the time to outcome? It could be a kind of artificial way of seeing whether GDF15 is, or to see how it is going in time.
We did not compare time to event analysis with GDF15, but this is a good idea to see if it would change.
Okay, thank you. I'll give the word back.
Okay, thank you very much. Then now I call upon Dr. Metting to continue the discussion.
Esteemed PhD candidates, I have some questions about chapter 2 and 3. And the first question is about some clarification. So you included the UK Biobank and also a Lifelines database. And in the UK Biobank, the age of the people was between 37 and 73 years. And you also report the main age of 58, so quite an older population. But in the Lifelines population, if I look at chapter 2, you say that the age is between 0 and 93. And in chapter 3, you say, okay, we only selected those older than 40 years of age. And there was also some another thing that puzzled me. So in the methods section of chapter 2, you say, well, the mean age of the population was 41 years. But if I look at the table, the mean age was 43. So, just in short, what type of people, considering age, did you include of the Lifelines population?
Very learned opponent, thank you very much for the question. This is a sharp observation. In chapter 2, we have a different inclusion criteria indeed with chapter 3. To keep it short, in chapter 2, we included any age of type 2 diabetes. In chapter 3, we indeed introduced a cutoff, and this was after recommendation by the reviewers to have more matched cohorts, the UK Biobank and Lifelines, because they were, of course, Lifelines is knowingly healthier and younger, so they wanted to have a more matched age groups in the analysis, and this is after reviewers' comments. We didn't do that at the beginning.
Yeah, and do you also think that, because type 2 diabetes also occurs in younger people, as we know now, do you also think that it might have impacted your prediction model, the fact that you included all age ranges in chapter 2?
In what way would you think that it would impact?
Yeah, you can compare both databases, so the UK and the Lifelines database. Do you think that it also impacted your findings, the fact that you included the whole population in Lifelines? So if you would have included there also only the 40 years and older, would your findings would have been different?
I don't think so. I think in the UK, I think in Lifelines, up until 40 and clinically, we don't see so many people with type 2 diabetes, now increasingly more due to obesity mainly. But I don't think that the findings would be statistically different than including the whole sample size based on the chronicity of disease that occurs in a later life stage.
Okay, that's good to know. Thank you for the clarification. Then I have another question, again about the populations that you have included. So questionnaires were used in Lifelines and UK Biobank, so that's quite clear. But the question was, so did these people fill in the questionnaires online or on paper or both? So how were these questionnaires taken?
I think the questionnaires were filled digitally via tablets. They were collected, I remember, in the UK Biobank. So this is not, to my understanding, on paper. I think it's done in a digital form.
Okay. So one thing I was a bit worried about, so if you look at the type 2 diabetic population and also the cardiovascular patients, on average, these are people with a lower socioeconomic status, older, and we know that that's also related to poorer digital literacy, of course. So I was wondering if all the questionnaires were taken digitally, did you also miss a certain group with poor digital literacy?
This is a very good question, and this also extends to the biobanks. So not only the questionnaires, but these people, of course, are not underrepresented in the biobanks. And even more so that other platforms like the TriNetX, which has a massive population, does not include any information whatsoever about socioeconomic index, which is a pity, actually. But this is something that we should all be working in the medical field to include more people from underrepresented areas, and then have questionnaires that also target them with social economic index or the socioeconomic status.
Yeah, for sure. Yeah, so you also discussed in your book that you recommend the use of these prediction models. For example, you said in primary care to do a screening. Do you also expect then differences? So if you use your findings from this digital population on the general primary care practice, do you also think there might be a difference in results?
So if I understand the question, it would be if I would screen people with lower socioeconomic status than the ones that are participating in the biobanks.
Yeah, if you would screen the general population in primary care practice, that also includes those without digital skills, of course, which is a little bit different than the ones you included in your prediction modeling. Do you expect any differences?
I don't think that this questionnaire requires tech savviness or any expertise in having any digital understanding. It's just filling out questions, and I think this could also be implemented by GPs. To answer your question, I don't think that there might be a big difference. Maybe in disease prevalence and disease incidence, and this might indirectly impact the findings.
Yeah, I think so too. Yeah, okay, that's so maybe we need to do an additional study in this group in paper questionnaires, for example. Yeah. I have one other question, so there's still room. So you also describe in your study, well, maybe we can also use it like in an app or digital tool or something like that for screening, but also maybe for monitoring. And I was wondering, how sensitive are these prediction modeling in changes of an individual? So let's say you start doing exercise and eating healthy. Would you be able to see that in the outcomes of your prediction model?
This is very interesting, and we have already made a preliminary study, not included in the thesis nor the publication list because it's still under work. But we have tried to do again the questionnaire and see in the longer follow-up of a UK biobank what happens, and we see that the individuals predicted as high risk do get diabetes. So I think this might be sensitive, but it might be good to do such a community initiative, as I said before, and see what happens if you launch an intervention in the meantime.
Yeah, definitely. Very interesting. I give the word back to the director. Thank you.
Thank you very much. Now I call upon Professor Bauma to continue the discussion.
Esteemed PhD candidate, congratulations with this fantastic PhD thesis, which I read with great interest and also brought me a lot of inspiration. In your thesis, you have different parts where you either use survey-based input to develop your models, and you also propose that we should focus on novel analytic methodologies to improve prediction, but you also use the new biomarkers based on proteomics. So after reading your thesis, it's still puzzling to me. If we want to improve prediction, should we focus on improving analytical methodologies, or should we focus on identifying new biomarkers based on omics analysis?
Highly learned opponent, thank you very much for this interesting discussion point. I think it's context dependent. That would be my short answer. And this is, for example, exemplified for type 2 diabetes and coronary artery disease. Doctors try to gather this information during the anamnesis out of questions that are empirical, never data-driven or validated in a cohort at such scale. So I think for diseases that are malleable and may occur in the future, and we can already do this based on very cheap lab work, then we could include questionnaire data. Then for diseases, for example, like muscle D, which requires biopsy, liver biopsy to identify as a gold standard, or dementia, which requires brain MRI, these participants should be followed at this stage at an academic center or at an expertise center, and there we could have biomarker discovery. So at the primary care, the first two chapters, 2 and 3, could go in the primary care with questionnaire data. Then for muscle D, liver diseases, or multimorbidity identification and dementia, then we could include more expensive biomarker analysis like with GD15. And then for treating these high-risk patients, the chapter 6 shows some pharmacoepidemiology study.
Yeah. So in chapter 4, indeed, you identify that GDF15 adds significantly to your prediction model. We already heard the proposition number 4, where you state that omics should only be included if they are of incremental utility. And there's some kind of catch-22, because how do you know that those omics or potential new biomarkers are of added value if you have not measured them yet? Can you help me here?
This is a good question. We didn't measure it for the 2 first chapters, no. Which is a good idea. We could have done it. But we did add normal lab work, and it did not significantly increase the accuracy of the tests so that this would be cost effective. So this is true what you say. We should add them to the analysis and report them maybe in the supplements or even in the main text. But implementing them in clinical care, that's something else. We should then check if it's cost effective at scale.
So how do you determine this incremental utility? Is it cost effectiveness? Should we look at clinical outcomes or other parameters?
I would first consider clinical incremental addition of value based on feature saturation curve, for example. That's, you can see one on page, let me get the figure, on page 43, figure 2. This is a way that we could add it to the model, for example. What added value does it have to either AUC or, as Professor Fairman said before, to decision curve analysis or other metrics?
Okay, yeah. Now, clear. So you also just mentioned that preferably those biomarkers should have the same price as CRP. Yeah. I'm working in acute care and I look at CRP a lot of the time, and sometimes I doubt why we even measure this biomarker. You also mentioned that these proteomics would cost approximately 100 euros. So should we not better focus on developing proteomics that can be implemented into clinical care instead of trying to do our best to identify the single biomarker that could predict the risk? And for this discussion, I'd like to specifically take you to one of the main health problems we have in acute care, namely patients with sepsis or at risk for sepsis. So what is your opinion? Should we do our best to identify single biomarkers, potentially better than CRP, or maybe use survey-based data here? Or should we make sure that we can measure the proteome at the bedside for 100 euros?
I think your question is very valid. In the acute setting, it's a different story because then it really matters to identify the high-risk patients as quickly as possible. And then what you should be striving for, I think, is to have the maximum accuracy. Then whole proteome assays will be way more efficient for you to include, I think, rather than a single metric. But for the time being, I think a single metric might be way more cost effective than having your whole proteome screened when this is not going to be implemented at scale.
So for the early future, you would say that these AI models might be better usable and able to implement in clinical care. And in the far future, pending technical developments, we should go for including also the omics measurements. That brings me to my question about implementation, which is not only about the technical aspects, having the data available, which is of course also challenging, but also the adoption by the end users. And in your discussion, you also mentioned the black box phenomena. Can you explain what it is and how it affects adoption of AI models?
So a black box, for example, is a deep neural network when it's not very easy to identify what coefficient each feature drags with it, as we see in a logistic regression model, for example. So then this will also be difficult for the clinician to understand what implications each of these proteins might have if you just put everything into a deep learning model. Of course, it can be partly explained, but there is also a Nature commentary that I read for this thesis that says, stop trying to explain black boxes, which is also very interesting. And I think for clinicians, it might not be easy to understand what value to attach to each of the markers that they measure, especially for physicians that are trained during my generation and before. We try to identify each lab value and then try to make connections across the values. But then if it's a black box, it's going to be very hard to identify what signal each one carries.
Okay, thank you for your answer. And for sake of time, I give the word back to the rector.
Thank you. The doctorate board will withdraw for some time to consider its decision.
Maar doe je niet van je mastervlak?
Before we continue with the PhD ceremony, I call upon Professor Henning to award the MD.
Thank you, Mr. Rector. I herewith open a special meeting of the Board of Examiners of Medicine and Dentistry, which only has one purpose, and that is to graduate you as an MD. And because it is a Dutch MD, I have to do this in Dutch, so I will continue in Dutch. Het eerste wat ik zal doen is de Nederlandse artseneed voorlezen. En daarna neem ik die graag bij u af. En de Nederlandse artseneed gaat als volgt. Ik zweer of beloof dat ik de geneeskunde zo goed als ik kan zal uitoefenen ten dienste van mijn medemens. En ik zal zorgen voor zieken, gezondheid bevorderen en lijden verlichten. Ik stel het belang van de patiënt voorop en eerbiedig zijn opvattingen. Ik zal aan de patiënt geen schade doen. Ik luister en zal hem goed inlichten en ik zal geheim houden wat mij is toevertrouwd. Ik zal de geneeskundige kennis van mijzelf en anderen bevorderen. Ik erken de grenzen van mijn mogelijkheden. Ik zal mij open en toetsbaar opstellen en ken mijn verantwoordelijkheid voor de samenleving. Ik zal de beschikbaarheid en de toegankelijkheid van de gezondheidszorg bevorderen en ik maak geen misbruik van mijn medische kennis, ook niet onder druk. Ik zal zo het beroep van arts in ere houden. Wilt u mij dan nazeggen? Dat beloof ik.
Dat beloof ik.
Met deze hamerslag bent u dan bevorderd tot arts. I just promoted Michail as a medical doctor. And I close this special meeting of the Board of Examiners.
Esteemed PhD candidate, the doctorate board of this university, represented by us, after reading your PhD thesis and the accompanying propositions, and after hearing you defend it, has decided to award you the PhD degree at the University of Groningen, which you desire. Your primary supervisor, Professor Henning, is authorized you to award you with this honor in the customary fashion.
I'm happy to accept the task assigned to me by the Rector Magnificus. But before doing so, I'd like to address a few personal words to you. Dear Michail, the first thing I want to do, and I do this also on behalf of my fellow promoter, Professor Mantzoros, and the co-promoter, Dr. Castela Forte, is to congratulate you with the PhD degree, which you are about to receive. And let me remind you, and all others, that this is the highest academic grade that can be obtained. And in that sense, your academic journey ends here today. But I'm pretty sure this regards only the quest for academic degrees and not your appetite to pursue a medical scientific career. Our journey started 3.5 years ago, and from my perspective, it was actually José who initiated this, telling me about this highly talented guy he was working with and setting up a meeting between the three of us. I think by that time, the two of you already made plans to make you apply for an MD PhD bursary. In the end, we wrote the application and you entered the summer 2023 round. By July, the verdict came. Rejected. Something that really hit you hard. But we quickly realized that this was the price we had paid for something the three of us had in common: enthusiasm. This has led us to try to cover way too much ground in the application. Luckily, at the same time, also your first journal article started to be published, and collectively that boosted us and to try once again in the October round. This time you passed with flying colors and started your MD PhD journey. Now, from this journey, I picked 3 things I want to highlight. The first, of course, is you, as a person, Michail. A highly intelligent and friendly person with a passion for data and public health. And a person with ambition, burning ambition, I might say. You want to publish a lot. You want to publish in the highest journals. You will enter any award competition that fits you. And you actively shape your future by submitting all kinds of grants applications. Often you are successful. For instance, you obtained a 2-year Rubicon grant, very prestigious grant from the Dutch Science Organization. And for instance, you have been selected by the National Academy of Sciences to attend the Lindau Nobel laureate meeting next year, so where you will be meeting multiple Nobel laureates discussing your own research. I thank Hanno Peil for the support he gave in obtaining this Lindau Nobel laureate opportunity for you. But there were also prizes you did not get. And it is characteristic that it takes you some time to get over that disappointment. But luckily you will, and I think there's an important lesson to be learned here, to realize that next to ambition, tolerance for frustration is another important trait of a researcher. A second highlight of your PhD, you know very well how to choose your mentors and collaborators. You've been collaborating with a lot of people. I did not count the number of co-authors on your publications, your impressive number of publications, I might say, but it must be at least 40 or 50, including your mentors from Leiden. It's a large group of people that contribute to your increasing set of research skills. And I think the group is spearheaded by José. The third aspect of your PhD, which actually is the fun one, it's the laptop. The moment you started, we agreed that you needed a good laptop. I don't know how many walls of blunt ignorance and stupid bureaucracy we hit, but it took us 2.5 years to get you the one we thought that you would need. Admittedly, this laptop just made it in time for you to put together the large document your thesis is. So it served its goal, and I'm happy that you can still hold on to it, at least for the duration of your Rubicon. And I wish it may continue to serve as a symbol of your perseverance. The most famous Greek literary work is Homer's Odyssey, an epic poem about a man sailing home while being challenged by gods, only to return after 20 years. Today, you end your academic odyssey by obtaining both an MD and a PhD degree. A journey that has been challenging, but also fun. And often you had tailwinds and occasionally strong headwinds. But in all fairness, I think this is the best you can wish for as conditions for the future. We wish you all the best and once again congratulate you with today's achievements. Don't forget to celebrate today. And afterwards you will continue your endeavors in Yale University. And although I always address you as Michael, I guess in the end José wins. It will probably be Mike for the next 2 years. Anyhow, good luck and lots of scientific fun. Will you all please stand? By virtue of the powers vested in us by Dutch law, in accordance with the decision of the doctorate board of this university, I, Robert Henning, confer upon you, Michail Kokkorakis, the title of doctor and all the rights associated by Dutch law or custom with a PhD degree at the University of Groningen. Do you, as a doctor, promise to act in accordance with the Netherlands Code of Conduct for Research Integrity 2018 of the Universities of the Netherlands, both now and in the future?
I promise.
You may be seated. Now that I have performed the task assigned to me, let me be the first to congratulate you on your PhD degree and address you as doctor. And as I do that, I will also hand to you this medal, which is the Haute Junior Scientific Masterclass medal, and it's awarded to you as a token of a successful ending of your MD, PhD trajectory. So, dear Dr. Michail, congratulations.
As proof of this PhD degree, I present you with the certificate signed by the Rector Magnificus, Secretary, and the Promotores, and with the Grand Seal of this university. But before doing so, dear Sir, it's my pleasure to congratulate you also on behalf of the doctorate board of this university. Bula promotion. It's in Latin, not in Greek, but also in English. As you can see, all the signatures are here. And this seal is just not a real seal, but a picture of it. Yeah.
Thank you very much.
I now declare the ceremony closed. Our colleague from Leiden, thank you very much for being with us and hope to see you again soon.
Thank you, Mr. Rector. It was my pleasure.